What is addiction?
It's scary.
It's confusing.
It hurts people.
Destroys potential.
Destroys lives.
But hold on.
Addiction is not what you think.
It's not a character flaw.
It's not a moral weakness.
Let's find solutions.
Real solutions.
But you gotta start somewhere. Start somewhere.
Start today.
Start here.
With Smart Recovery.
We've been a vital part of the solution to the addiction crisis in America for over 25 years.
Be part of it.
Well, what should I say about Jonathan von Breton? Jonathan von Breton was involved with Smart Recovery for almost 30 years. He overcame a great disability in order to become a counselor and a teacher of REBT, Rational Emotive Behavior Therapy, which he learned at the foot of Albert Ellis himself. He was devoted to Smart Recovery as a teacher and as a facilitator, facilitated hundreds, maybe thousands of meetings. Jonathan was a pioneer in the area of online Smart Recovery meetings, of which there are now 700 every week. We are greatly appreciative of his devotion and passion in developing that area of our approach to the public.
Smart Recovery's Jonathan von Breton Lecture Series is proud to present Dr. Nora Volkow as our speaker today. To introduce Dr. Volkow, please welcome Smart Recovery co-founder and former president, Dr. Tom Horvath.
Hello. Welcome to the Jonathan von Breton Memorial Lecture Series. Thank you for joining us. I want to recognize the extensive efforts by Bill Greer, Smart USA President, Mark Ruth, our Executive Director, the staff at the National Office, and Dr. Joe Gerstein, also a co-founder of SMART. Thank you. We hope you enjoyed the video about Jonathan. He was a tremendous force for good. Dr. Nora Volkow, Director of the National Institute on Drug Abuse and our inaugural speaker, has also been a tremendous force for good. Dr. Volkow is a world-renowned expert on substance problems. She is the recipient of numerous awards. She has written prolifically and has edited 4 books on brain imaging. She has been a pioneer in using brain imagery to combat moralistic views about substance problems. Dr. Volkow has called for moving beyond abstinence as the only goal of treatment and encouraged conversation about harm reduction. Her views align well with Smart Recovery. Since Smart's inception, we have supported medications, combated stigma, and promoted multiple pathways of change. We are proud to be part of efforts to be more pragmatic and realistic, the subject of Dr. Volkow's talk today. Dr. Volkow, welcome to our series. Thank you for being here.
Dr. Horvath, thanks very much for having me. And to me, it's an honor to be the first presenter on the memorial lecture for Jonathan von Breton. And I think it is quite extraordinary to follow an example that inspires all of us. And I think that it is that inspiration that also brings us together and says, what is it that we can learn from what we're exposed and how, in order to be able to do things better? And that's ultimately the tenure of my talk. With that, I'm going to share my screen. And the first slide is the presentation obviously comes from the vantage point of my representing the National Institute on Drug Abuse, which I've directed, and whose mission is to advance science on the causes and consequences of drug use and addiction, and to apply that knowledge to improve individual and public health. And so it is not just the notion of knowledge for knowledge's sake, which of course is a very important human endeavor, but even more consequential is the use of that knowledge in ways that can improve the life of others. And for us in the field of substance use disorders is to improve the lives of people that have been very much neglected by society and that in fact have been targeted for stigmatization and discrimination. The way that I look at our portfolio, I like to say, okay, what is the science that can help us address the most sort of consequential intervention that we can do for any medical disorder, which is prevention. So how does knowledge allows us to do prevention in ways that are likely to be more effective? The other one is knowledge that can help us actually develop better treatments, whether it's medication, behavioral interventions, or other approaches. And importantly, that knowledge requires that we know how to apply it in order to translate it into changes in practices, into policies, into new products. And that is not automatic. That actually requires a very concentrated effort and well planned in order to make this happen. As it relates to prevention, I'm just going to present a slide on it. The two most important studies that we are launching towards this is to use advantages of the extraordinary technologies that we have accessible to us that enable us to investigate how the human brain develops and changes through childhood into adolescence, into adulthood, how environments affect that brain development, how genes interact with that brain development. And this is important knowledge because it can help us start to understand why adverse childhood experiences, for example, which have been shown by multiple epidemiological studies to significantly increase the risk of substance use disorders, as well as other mental illnesses. How is it that they are producing this? And by actually investigating, taking advantage of these sophisticated tools, and designing large studies that are very well controlled, we can start to disentangle this. So there are two major studies that we launched. One of them is in 2015, the Adolescent Brain Cognitive Development Study that follows close to 12,000 children that were recruited when they were 9 to 10 years old, and we're following them across all of the country for over a period of 10 years with very precise brain imaging, cognitive assessments, behavioral assessments, use of monitors and social behaviors. And this study actually already has proven to be extraordinarily valuable, and it has enabled us to dissect, for example, as this study shows here, how adverse environments, in this case, children that live in the neighborhoods that are deprived, have a much lower development of prefrontal areas of the brain than those that come from environments that are very much enriched, highlighting the importance in the human of exposing individuals to environments that are actually going to promote the further development, as opposed to environments that are basically sort of restricting and interfering with that development. So this was started in 2015. The other study is the Healthy Brain and Child Development, which was started last year on September of 2020. And it aims to follow 7,500 infants that are less than 6 months of age as they proceed into 10 years or older. Again, periodically evaluating them for brain imaging, for behavior, for their family structure, in order to understand what we've already known too. Again, this is a study done in orphans who actually, if you are to think of a state where the enormous amount of deprivation, social deprivation, is children that have lived in orphanages, where you don't have the social support necessary to promote the brain. And these studies have now shown that there is, in fact, delay of fibers, that the fiber tracks that connect different areas of the brain, for example, those between the frontal cortex, which allows us to have self-regulation, abstract thinking, and the limbic brain, which is our emotions, is very markedly affected in these children. And the longer they are in the orphanage, the worse it is. Now, these studies were done on relatively small sample sizes, so it is very difficult to disentangle differences between children and to also follow and find out if you can improve these environments, can you actually allow the brain to recover, which is what the data seems to suggest, and which is where the value of studies like this one will enable us to provide much better tailored prevention interventions that can actually maximize the proper development of the brain and also minimize potential negative consequences in the environments or in genetics, as we have a better understanding what genes make actually someone more vulnerable. The other area that has been a priority is the one of treatment, as I mentioned. And the way that we look at helping to develop treatments is, on the one hand, actually looking in medications offer a unique opportunities in the case, for example, of the crisis that we're dealing with, the opioid overdoses. Medications for opioid use disorders, whether it's methadone, buprenorphine, or naltrexone, have proven to be the most effective interventions. Similarly, medications like naloxone have been completely life-saving because actually when delivered on time at the adequate dose, they save lives. And it has been actually, we're very lucky to have naloxone as a medication that can be so extraordinarily effective. So we know that. The question is, how do we, a simple formulation for us is developing formulations. That is to say, are there ways that we can improve retention in treatment for patients, making it easier for them to comply with the medications? And are there ways that those formulations can also improve recovery? Then there's the aspects of research that is very transformative, that looks at completely different options. And I'm highlighting for a completely different option, the development, for example, of vaccines or monoclonal antibodies. Just like we've seen it for COVID, you can generate vaccines that actually will produce antibodies against the drug itself to vaccinate. And the vaccine actually activates the immune responses such that you generate monoclonal antibodies for that drug. When the person takes the drug, the monoclonal antibodies sequester it in the blood and cannot enter the organs, including the brain. And such strategies could be potentially very helpful, not just for example, for preventing toxicity from fentanyl or methamphetamine, but could also be potentially useful in the treatment of substance use disorders. And the third approach relates to the understanding that we have now about which are the brain circuits that are affected in the state of addiction, which of course has repetitive cycles that go from intoxication to withdrawal to craving. And during these cycles, different areas of the brain are engaged. And now with technologies like transcranial magnetic stimulation or transcranial direct current stimulation or ultrasound or peripheral nerve stimulation, we can affect these circuits in which that can, for example, we can aim to strengthen executive function by actually activating the prefrontal circuits, or we can aim to actually decrease the craving and ruminations by inhibiting interoceptive systems in the brain. So understanding what are the neurocircuits that account for the symptoms in addictions, when coupled with technologies to activate or inhibit these systems, has offered us a completely unique way to go after them. And of course, what we are also very aware of is the importance of also maximizing benefits sometimes by combining interventions. So it may be, for example, that the use of neuromodulations with behavioral therapeutics or neuromodulations with medications may actually significantly improve retention and outcomes. It has also become clear, and I think that the introduction that was made of me, that we need to also understand what are the practical aspects of developing treatments or interventions to help people. I think that in many instances, we have wanted to actually have like this magical thinking of here comes a treatment that is going to get rid completely of the addiction, without an understanding that addiction connotes two elements. One of them is, of course, what led the person to be vulnerable, an environment or situation that actually led them to try to escape that state and use drugs, or easy accessibility or genetics that lead them to actually be risk prone, regardless of what those conditions, those elements are there. And the other one is the moment that you start to take drugs, and particularly if you become addicted to them and if you have a severe addiction, that's going to have a downstream domino effect that's going to interfere with your social support systems that include your family, relatives, work. And those systems are extraordinarily important for the well-being of the brain. And to the extent that you are eroding them, the more severe and the more chronic case, it becomes a little bit, I think, magical thinking to think that we can come up with a pill and all of this is going to disappear. You have what preceded, you have the effects of the drugs negatively impacting the brain, and then you have the consequences of those changes in how we structure our lives. And so understanding that and aiming to come therapeutic interventions that understand this complexity and that bring forward opportunities for helping people achieve recovery and based on where they are and what would basically will help them, as opposed to top down and say everybody should go for abstinence, even though in many instances people are unable to stay abstinent. And so washing our hands of those situations has been very, very negative and results in terrible outcomes. So we are bringing up and working with the FDA to try to figure out how can we advance treatments that will not per se use as the outcome abstinence, but instead use functions that are valuable for the individual suffering from these diseases. So can we have treatments that reduce the use as opposed to complete abstinence? Can we have treatment that decrease the craving and therefore the malaise that the person has for not able to stop it? Can we improve cognitive function? And that will help persons that are taking drugs be able to engage better on therapy and on everyday activities. Can we improve sleep? And many patients relapse because they cannot sleep. And insomnia is one of the most stressful situations, or others that are valuable. And in order to make this happen in terms of we're funding research that can help us identify the value of getting these metrics such that the FDA will be willing to consider them. And you may ask yourselves, why are we concerned about getting them approved by the FDA? And the reason why we are is that we've come to realize that if there's not a monetary incentive, then it is very unlikely that those treatments will be deployed. And so we have to show not just that the treatments work, but we have to try to advance it in such a way that we're going to ensure that those treatments will be available for people that need them. And in many instances, that requires that they be reimbursed, for which actually having FDA approval is very important. Now, let me now shift gears and to try to take a step back and say, okay, we have lived 2 years, all of us, in a sort of a period that has been so very different from anything that we've done. And from the perspective of the substance use disorder, of course, it has been very, very devastating. And within that devastation, I think that we owe it to everyone, including ourselves, to look at it and say, what have we learned? And out of those lessons, which are the ones that we should be prioritizing? And why do I say this? I say this because when you are in a crisis actually make very, very evident conditions in which you have actually gaps. So vulnerable systems become very, very obvious, and when there is a crisis, they may be hidden a little bit under regular situations, but not with a situation of crisis, as has been on the one hand the opioid epidemic, yes, and now the overdose epidemic, but with the COVID pandemic, I mean, so you have two major stressors affecting our lives, and so what have we learned from it? Well, clearly what the COVID pandemic showed us was the vulnerability of the treatment systems that we have for supporting people with substance use disorder. They were utterly inadequate. And to a certain extent, I think that we have already realized that with the overdoses that we were living and the inability to provide with treatment and support. But I think that the COVID pandemic just made it very clear. And similarly, the limited access to peer support groups or other sources of social connections, which are fundamental and crucial to actually initiate engagement of someone to try to help them to get into treatment, and if they are on treatment, to ensure that they achieve recovery. And two, it became clear how negative social distancing was as it related to, basically contribute significantly to relapse rates among people that were taking drugs that were trying to control it. And this, in my brain, like nothing else, has highlighted something that we've known all along, how important social systems are for people that take drugs, and how they basically, the addiction itself makes those social systems increasingly more punitive and increasingly less supportive. I think that the issue of homelessness came to the fore during the COVID pandemic, and homelessness actually puts people in an extremely precarious situation with respect to their health, with respect to their inability to stay in treatment if you're homeless, but also importantly, inability to achieve recovery. If you are homeless, how are you going to stabilize your everyday life? And of course, we've known all along the stress, uncertainty, loss of jobs was very clear. And it also became very clearly how devastating stigma has always been, but actually even worse during the COVID pandemic. And stigma actually, on the one hand, makes people embrace that stigma in many instances to themselves. They stigmatize their own selves, but also leads them to not want to seek help because they don't want to be discriminated or maltreated. So the COVID pandemic identify all of these gaps in a clarity that I think that right now we really cannot ignore, and puts in an urgency to address them. I guess that the illicit market was very, very smart in recognizing that situations of crisis are situations where make people very, very liable to taking drugs. And so, no surprising, during the COVID pandemic, there have been significant increases in use of all drugs. But in the case of the illicit substances, what it also has meant is that there has been a significant increase in the availability of these drugs in our country. And this is data that gives us an idea of this, that reports on the total drug seizures in the borders, Border Patrol, office field operations, and air and marine operations from fiscal year 14 to fiscal year 20 for different drugs. And what you can see is before the pandemic, 2019 to 2020, we had seen already a rise in cocaine. And there's something in the 2019 year, there was significant rises in multiple drug use too, but nothing as what we saw with 2020. In 2020, look at the significant bump on rise on methamphetamine, and look at fentanyl, how it had been going up every single year. But from before to after the pandemic, it basically had an increase of 60-70%, a massive increase. And this has been associated, continued in 2021. We have data that actually has showed, I think, like a six-fold increase in number of seizures. And interestingly, something like a 3,000-fold increase over a period of 4 or 5 years in the number of illicit prescriptions that are contaminated with fentanyl. It has just flooded the market like we have never seen. And that combination of the fragilities that we have in the system that is there to support people with substance use disorders, and the expansion of the illicit market, particularly for extremely toxic drugs, methamphetamine and fentanyl, also very addictive, was actually the responsible for what we have been observing, which is the very dramatic rise in overdose deaths during these 2 years of the pandemic. And in September 2021, it was actually in June 2021, for the first time, there was the milestone or more than 100,000 people dying from overdoses. Never, ever in the history of the United States have we had a number like that. And so this is data that actually goes beyond June 2021. It's from the 12 months that preceded September 2021, where that continued to increase. Now there are 104,000 people that have died as of September, compared to very high numbers in 2020, 90,000. And as I say, 2019 was also an increase, but nothing at the level that we saw with the COVID pandemic. So for this year that ended in September 2021, the overall increase in mortality was 16% from overdoses. And when you think about these numbers, what is important to note is that this increase is on the basis of very high numbers. I mean, it's an increase over 90,000 people dying, which is again extremely high, nothing like we had observed ever. Just to get you an idea, for many years, the annual overdose deaths from heroin for many, many years were 2,000. Now just jump at where we are right now. And look at the different contributions for the different drugs. Interestingly, heroin deaths have gone down. And this reflects the fact that for the drug dealers, it's much more profitable and easier to bring fentanyl into the United States and sell it than it is to heroin. So more and more, we're seeing that what is people are consuming, believing it's heroin, is actually fentanyl. And more and more, it is hard to get heroin that is not contaminated with fentanyl. So we see the maximal increases when you look at drug types. By fentanyl, close to 26%, and methamphetamine, close to 36%. And I want you to know that the number on methadone, I mean, basically on methadone overdose deaths, even though there will be significant increases overall, we have not seen methadone significant increase in methadone overdose deaths. And I'll bring that up because I think it's a notable statistics that we have been monitoring all along, because we wanted to be sure that the changes that happened with the COVID that allowed to take home methadone will not be associated with increases in overdoses. And what we've shown and others have shown is that no, there is not an increase in methadone deaths. What there is an increase is both fentanyl and methamphetamine overdose deaths. So within this panorama, or where we are with an extremely dangerous illicit market, and the COVID pandemic with all of its challenges, there were changes in policies that actually allowed to buffer what would have been otherwise much more negative consequences. We're all aware that in March, there were 2 changes that facilitated take-home methadone programs, enabling the methadone treatment programs to provide 28-day take-home to patients that in the past had to go in a daily basis. Very few patients were authorized to take home methadone. With this change in policy, this actually expanded the take-home methadone. And that's why we were keeping an eye on those numbers, and we have followed it since then. There's no evidence of increases in overdose mortality from methadone. On the other one, for buprenorphine, it actually facilitated access to buprenorphine, not requiring, as it was the past, to actually have to have a physical presence of a physician. You could get the physician prescribe it to basically telehealth or through a cell phone appointment. And the physicians could prescribe across states. And that also incredibly facilitated recruitment and basically induction into buprenorphine treatment for patients. And these 2 measures, there's actually have been shown to significantly improve outcomes. And this is data that was recently published from Canada that actually was evaluating. They had a similar change in policy that facilitated take-home doses of methadone, and they look at what happened when they facilitated take-home methadone, which are these 2. These are take-home methadone, whether they were already on take-home or whether they were allowed to actually take it for the first time. And what we can see that the opioid overdoses are much lower. The discontinuation of treatment is much lower. The interruption of therapy is much lower. And it behooves us to look at this and say, if it is not associated with negative outcomes overall, what is it that we need to do to actually make this a permanent solution so that patients can be much more easily able to access their medication without having to actually make a decision on every single day to actually go into the clinic to get their treatment. Within this context, of course, we'll develop models that can also be utilized to help us identify instances where a patient may need to have that level of surveillance. And if it is a methadone clinic is not nearby, now with telehealth, we have an opportunity to actually do follow-up in ways that were not possible in the past. And that brings us to other very important changes that happened with with the COVID that are very consequential for us in the substance use disorders field. One is the increased use of telemedicine and reimbursement. Telemedicine was there, but its reimbursement was very cumbersome. And approvals for telemedicine were also extremely difficult. And as a result of that, it had been used and it showed that it was beneficial, but it hadn't been taken up with the COVID pandemic that changed one day to the other. And this allowed to provide expanded access to treatment of comorbid conditions, whether it was other mental illnesses or medical diseases. It expanded access to behavioral treatment. So treatment programs that in the past or physicians would not evaluate or treat patients because they didn't have the behavioral support, with telemedicine now could actually provide it. It also facilitated the establishment of mental health hotlines, and it also allowed for the deployment of virtual support meetings and coaches. And as we think forward, because I want the leitmotif of my talk to be how important social support systems are for treatment and for recovery, we can start to understand how crucial this element of telemedicine or telehealth is. And the importance, again, I'm going to emphasize our opportunity to generate data that will ensure reimbursement for these services so that they are sustainable. In the justice settings, there were also very dramatic changes, including the release of nonviolent offenders. Many of them had substance use disorder. They were released from jails and prisons. And basically offering up the opportunity of addressing that question about why the need of incarceration, and which is, we know, is linked with very negative outcomes, including higher risk of overdoses. It also facilitated the use of telemedicine in jails and prisons, and telemedicine was very restricted, and that has changed dramatically. And so has the openness that has enabled the ability to provide medications for opioid use disorders in ways that are much easier, as well as to provide a sort of support for other psychiatric disease conditions or mental health consequences. And ultimately, the web-based offers opportunity for people that end up in the justice setting for getting an education that will make them better able to succeed when they are released from the jails and prison systems. All of this has made us realize that we now have tools that are basically expanding our capabilities, and it's forcing us to think about how do we use them to change the way that we've been doing things in ways that are more sustainable and accessible and equitable. And for example, all along, we've been very interested on ensuring that basically taking advantage of primary care infrastructure in our country to engage them in helping identify people with substance use disorders, whether it is in the early stages or the more severe stages, and doing appropriate interventions. Take advantage of the emergency department, which actually is exposed to extremely sick patients go there for overdoses or other medical emergencies linked with their substance use disorder, for them to be actively involved in treatments or referrals. Infectious disease clinics for the same. They get involved in the management of the infectious conditions that people with substance use disorders may end up having, but they are not treating the substance use disorder. Clearly, the importance of integrated care is again highlighted across all areas of medicine, and that integrates typical healthcare with behavioral care, and more recognizing that community care is also another aspect that offers unique opportunities to improve outcome for patients. The use of pharmacies, for example, for delivering treatment is already applied. For example, in the case of diabetes, there's no reason why we cannot utilize pharmacies to help actually manage patients that have a substance use disorder that are being followed with medications. Research is ongoing, and places that have identified mobile units to provide patients that cannot access healthcare with such a capacity. The mobile units can have healthcare providers directly, or they can be they can do it through telehealth, allowing the person to have access to telehealth if they don't have the bandwidth that's necessary, and linking them to experts. There are multiple models, and including actually models that are targeted towards justice settings. And because of everything that happened that forced the communities to come up with solutions during the COVID pandemic, there is now clear that many of these alternative models actually have been used during the COVID pandemic, and they have positive outcomes. For us, I mean, that do research, I mean, obviously it's not just to show there is some evidence. We need to actually document that we can replicate that evidence so that and understand what are the components in order to ensure proper implementation of these alternative models. So we launched 3 very large projects that build that infrastructure. One through the clinical trials network that enables us to provide, for example, to investigate new models of care that can take advantage of healthcare systems, community programs, and peer navigators. So create models that are diverse in terms of the individuals that are engaged with them. A second one is the Justice Community Opioid Innovation Network that, again, offers a similar model to that of the CTN, but within the stakeholders that are involved in the justice communities themselves, learning from them and engaging them into a partnership with healthcare system, bringing both the justice and healthcare component to ensure that individuals that end up in justice settings are able to actually ensure, on the one hand, proper treatment for their substance use disorders, and then ensure that when they are brought back into the community, they will have the support systems. And importantly, to question actually the need for bringing into jails or prisons individuals that have a substance use disorder and thinking of alternative models. And then the final one is the Healing Community Study that basically has targeted 4 states with some of the highest rates of overdose mortality to basically do a very ambitious implementation program that brings together healthcare, justice settings, communities, but also the multiple agencies, and teach us how to optimally work across all of these systems to actually maximize the outcomes for individuals suffering, in this case, for an opioid use disorder. These programs have already taught us a lot. For example, this is a study done from the CTN that shows that in the emergency department, individuals that come with an overdose can be, in that same day, initiated on fairly large doses of buprenorphine that will allow them to actually basically stay in treatment and prevent them from actually overdosing. And this is very amenable because what's happening right now is people end up with an overdose, end up in the emergency department, they get resuscitated with naloxone, they get released into the streets, and then they basically immediately relapse within 24 hours, and many times with multiple overdoses. And only a very small percentage of individuals that go through the emergency department, it's been estimated perhaps at 16 to 20%, will have been received medications otherwise for an opioid use disorder, despite the fact that they overdose. So this shows that it is feasible, and now we're doing an extended study across all of the United States. And this is a study that was published last year that actually is in a small sample size, but the effects were so gigantic that they actually don't even need any statistics to see the differences. This is initiating buprenorphine of 2 different formulations: extended release buprenorphine, you only need to get it once a month, versus the sublingual buprenorphine that you need to give on a daily basis. This very simple intervention, just before you get your release from prison the month before, resulted in significant benefit. And the benefits were much greater for the extended release. You see a much greater number of them were able to be retained in treatment. They were able to provide negative samples for opioid, and there were much lower levels of reincarceration. You don't need statistics. I mean, it's very rare that you see these gigantic differences on something that is basically both of them are getting treatment, and buprenorphine helps everyone. But those that get the extended release formulation that is covering them for 1 month, again, similar to the narrative that we were using with methadone, you have to decide on a daily basis to take methadone. You have to decide on a daily basis to take buprenorphine. This is another example of a study about how powerful that, in this case, they are not working with extended release buprenorphine, just buprenorphine in jail. And it's also, they received buprenorphine while they were in jail. Those were the ones in blue versus compare with our equivalent community jail that did not provide buprenorphine, and then they follow them. And yes, indeed, individuals that were basically received buprenorphine have much lower rates of recidivism. They're much less likely to be rearranged and much less likely to be reincarcerated. So initiating buprenorphine treatment during the stay in jail or the month before will significantly improve outcomes in terms of relapse into drug taking and overdosing, but also will decrease reincarceration. And I think that data like this one, in my view, is actually as powerful and as impactful as many of the other interventions that we have seen with respect to COVID, what has worked with COVID, right? Well, here we have a very large effect. And as we discussed from there to sort of ultimately, what is it that we're aiming, right? We basically, of course, want to protect people from overdosing, and we want to ensure that they are able to actually have healthy lives, and we ultimately want them to be able to recover. But we also realize that this process from taking drugs into recovery is sort of, again, the question of magical thinking, that you can do it in 24 hours or 1 month or 2 months or 3 months, is very, very naive from what we know, because these changes are very pervasive in the brain and they're very long lasting. And they are also driven by aleatory factors, such as what happens in our lives that can be completely out of our control. So even though theoretically, yes, of course, we want people to stop taking drugs and to basically reinsert themselves into society, that's much easier said than done. And to the extent that we view that reality, I think we can come solutions that are likely to be much more effective than these sometimes what I think is really magical thinking goals. There are many harm reduction activities in this respect that can help us ensure that time that where a person is not ready to go into treatment or to stop taking drugs, nonetheless, we can improve their outcomes. And that will be beneficial to them, to their family, and will also improve the likelihood that at one point they may be ready to actually start treatment programs. Perhaps the most investigated one has been the use of interventions, harm reductions for reducing bloodborne infections, HIV and viral hepatitis, as well as endocarditis. And in terms of HIV, there are specific interventions that relate to treatment that can help you prevent if you get exposed to it. Treatment with antiretrovirals is, again, another very effective intervention to improve preventing infection. The same thing, treatment, now we can cure hepatitis C. If you cure someone from their hepatitis C, they basically are cure themselves, but they are also not going to infect others. And yet we're not deploying those treatments. So we have treatments that work and could be, if we deploy them, we could actually prevent other infections. We know that syringe exchange service programs work at many, many levels. We don't need to do more research about it. And yet what becomes very frustrating is that we see communities closing the syringe services programs, even in places where the rate of injection drug use is quite high, and with devastating consequences. So that, again, you can predict, you close a syringe service program, and you can predict that you will see a rise in the hepatitis C infection, and you will see a rise in HIV infections. Reduce overdose deaths, that has become a priority overall because the drugs right now are so dangerous. Opioids, the danger from opioids relates to the fact that they are basically depressing respiration. The stronger the opioid, that is fentanyl, is stronger than heroin, is stronger than morphine, the higher the risk for an overdose. But we have, as I say, naloxone is quite impressive as a medication. And if you provide it in time and an adequate dose, you will reverse overdoses from fentanyl, heroin, or even carfentanil. It works. You need to give it at the adequate dose at the correct time. We also basically has been a lot of interest with the current administration on providing with fentanyl test strips, because now what we're observing is people are overdosing, not just those that have an opioid use disorder, but they are overdosing many of them that have, for example, a stimulant use disorder, and they don't know that the cocaine or methamphetamine they are buying contains fentanyl, and that could lead to an overdose. We also see that people who are experimenting with drugs that are occasional users and get an illicit prescription from the web, for example, they can actually overdose if it happens to be a pill that's contaminated with fentanyl. And in 2021, there were 10 million pills that contain fentanyl that were actually captured in the United States. So they just proliferated. There's also been a lot of interest on actually understanding how safe injection sites could help prevent overdoses, certainly in Australia and in Canada, in some of the European countries, they have shown to be beneficial, particularly in cities where you have a high density and where it's actually can become a very viable alternative. The other aspect, as we're looking at harm reduction, we should also, I like to think about also increasing access to health services, and that's extremely important component, because what the COVID pandemic has shown us is that people with a substance use disorder were not only affected greater vulnerability for overdosing during the pandemic, but we also observed that they were more vulnerable to getting infected. And if they got infected, they got more vulnerable to have adverse outcomes, including death, much worse. And that led us to realize that what's happening is people with substance use disorders have much higher prevalence of severe comorbid medical conditions. And the severe medical comorbid conditions is not that per se just the fact that on one hand, I mean, drugs can affect different organs and systems, but importantly, that people that take drugs don't access the medical healthcare system. And when they access it, they are mistreated and not offer proper care. So that's why I put it as a really extremely important component. And then I also think that we should aim to, as a harm reduction, provide support to improve physical health. And through that, while it may basically not per se directly say, okay, it's going to stop taking drugs, it will actually allow for the individual to have a better sense of self and well-being that will counteract some of the factors that may have initially even driven them to taking drugs and that may have been exacerbated by drug taking. So what are we doing in the space of recovery research at NIDA? We have two large programs, two sort of group of projects that I want to discuss. One of them is through our clinical trial networks, and there are 3 different projects ongoing at the CTN. And 2 of these projects are very much based on trying to understand and optimize the use of peer support, peer recovery support to help people on the one hand achieve recovery, but also to use peer interventions to link individuals that are overdosed with treatment. And we're also using the peer support mechanism to understand how can we help people stay long-term in treatment, retain them in treatment, but also help them at the point that they are actually ready to, if they are ever ready to discontinue pharmacotherapy, how can we use those services to also maximize success and minimize untoward effects. And the other program is a research network for the study of recovery support services for persons treated with opioid medications for opioid use disorder. And through this grant mechanism, we offer support infrastructure that allows this recovery research to happen. And we bring together the various stakeholders, researchers, students, recovery support services, providers, public and private payers, and individuals in recovery. And these are 5 of the programs that were currently funded during this support. One of them is family-based. The other one is advancing recovery in Central Appalachia. And this is one to advance research on recovery for high-risk individuals that are emerging from justice settings, involving, again, communities in the process. And also understanding what other infrastructure and how to make it sustainable. And the last slide is the slide that brings me back to the whole notion about why social support systems, as we think about social support systems being crucial for actually being one of the factors that if you have them, that will provide you resilience for taking drugs and for protecting you against substance use disorder. Or if these social systems are not there, that will make you vulnerable. If you are already addicted and you want to go to treatment, those social systems can make the difference between staying in treatment and achieving recovery or relapsing. And this is actually exemplified in this very simple study on the very simple model of a rat that has two options. On the one, they can press a lever, whether for either heroin or methamphetamine, it doesn't make a difference. Very, very addictive drugs. But in the other one, we give them a choice, social support, social lever, where they can interact with another animal. And what we see is when you offer that social support, the animals don't take drugs. They don't. But then if you have exposed them actually to the drugs and you basically make that social reward penalized. So you put an electrical current when they press the lever to get the social support. You penalize it, like when you go and you ask someone for help and they basically mistreat you. That's a penalized social interaction. You withdraw. I mean, it's expected. As you can see it in this very simple model. Then they take the drug. And so the whole notion of when we're looking about what is it that we can do to prevention, what is it that we can do to ensure that people stay in treatment, what is it that we can do to ensure that they recover, I think we have to realize that we have an extremely powerful tool, and that is each other. And to the extent that we actually commit each other to help the other and to provide the support systems that they need, we will help them. But to the extent that we continue to do things the same way that we've been doing, penalizing, stigmatizing, discriminating, the only thing that we're doing is making people more vulnerable to take drugs, making them less likely to seek treatment, and making it very, very difficult for them to achieve recovery. So as I end up my slides with the basically the HHS overdose prevention strategy, I want to highlight again, whether it is the primary prevention, whether it is the harm reduction, whether it is the evidence-based treatment, whether it is the recovery support, all of those four elements rely very much in these social support systems. And by default, these social support systems, for them to be effective, have basically to be equitable and accessible to everyone. Thanks very much for your attention. And I'm going to stop my presentation here.
Dr. Volkow, thank you for that highly informative presentation. I believe we're going to be quoting you often. We have each other. And we collected many questions, far too many that we can get to. But one, what suggestion do you have for clinicians who want to help the addiction treatment industry become more pragmatic?
Well, I think that one of the aspects about it is that we need to have an understanding of ultimately what's the knowledge of the field, right? What is it that we know that works and what is it that we know that doesn't work? So the first thing that I would say is to, in any one of those systems, if I would basically promote the use of quantifiers of quality, and quantifiers of quality as it relates, for example, with respect to whether that particular treatment program has the elements that have been shown to be necessary for good quality care. That's one. But also get the qualifiers as it relates to long-term outcomes, and those long-term outcomes coming from the family and the patients themselves. And so if you have those, if you can monitor these, you can then start to adjust what practices are more likely to be successful. I would also highlight right now in terms of practical approaches that with telehealth, we can be very creative in providing high quality care that is that basically becomes more accessible through telehealth, taking, as I mentioned earlier on, taking advantages of trained nurses or advanced providers that can then contact with, through telehealth, with a specialist, will make it so much more widely available than trying to rely right now. It's you send the person to the specialist. Well, why not use these virtual environments to try to maximize treatment? We've come to realize, for example, also that many of the things that we did in the past, like for example, in terms of treatment of alcohol use disorder that require detoxification, that you bring them into a clinic, is no longer necessary, and that there are ways, again, to monitor these patients with all of the wearable devices. So this is a time for innovation and to take advantage of them. For example, we promote research on innovation, and one of the things that we're very interested in on developing methods, different types of methods that are monitoring, for example, when someone may be going into an overdose, and such that we can do then an intervention to prevent them from going into that overdose. And similarly, we're trying to promote research using wearables that can help us identify when you're following someone, a patient in treatment or in recovery, to identify when they are in dangerous situations for relapse so that you can alert them. So there are many ways that we can now intervene that were not available in the past. And interestingly, COVID has accelerated all of that space.
Thank you. I believe we have time for one more question, and this question might have a long answer, but we'll need the brief one. Many people decide to provide addiction treatment or conduct research, as you have, because of life-changing experiences. Would you be willing to share what motivated you to dedicate your life to this work?
Well, in 1 minute, it's hard for me to actually simplify it. I do basically can know that two events. One of them is my grandfather on my mother's side committed suicide because he couldn't control his alcoholism. And that was a taboo in my family. Nobody spoke about it. And it was very painful to me to realize this. And the same thing, the silence that prevailed and the lack of understanding of what was going on and how much suffering it created in the family. So in my view was, how can we understand that better? And then as a physician, as a medical student, and then as a psychiatrist, I was frustrated day and day again by the utter ignorance and dismissing of people that take drugs and the tremendous stigma that existed and the way that they were mistreated. And that element of actually not understanding and the inability to feel empathy, even as a doctor, for someone that is clearly suffering and that affected negatively their medical outcome. To me, that's those two things I would say. And then the third one, because that's ultimately what led me to say, okay, I'm going to take the position of director of NIDA, because I love the research, was that whole notion of incarceration of people that are addicted and the discrimination that has been done against Black American on the basis of addiction. So the notion of criminalizing people that take drugs, the lack of involvement of the healthcare system, and my own personal story. So all of them came together, and I guess that's why I'm here right now.
Thank you so much. We've had scientific and professional and personal glimpses into you and your life, and we very much appreciate it. In the interest of time, I'm turning this over to Dr. Bill Greer, President of Smart Recovery, and he will close down our hour. Thank you so much, Dr. Volkow.
Thanks to you.
Thank you, Dr. Volkow. I think you started a conversation that we're going to be continuing and follow-up conversations with you and your leadership. We're also going to be having some podcasts with leaders from NIDA that you'll be able to see on Smart Recovery. And we also are going to be inviting the people who've attended this presentation to follow up with a town hall conversation to talk about what Dr. Volkow has mentioned, what lessons we've learned, how we as an organization and a community can follow up and learning from and applying the lessons that you're suggesting that we follow. I think we're already doing a lot of what you're suggesting. We need to figure out how to do it more effectively and more broadly. I think that's probably one of the biggest challenges, making our programs and services accessible to as many people as possible, particularly as we rebuild ourselves as the pandemic winds down. I don't know what to call it anymore. Anyway, we learn to live with it. And so anyway, thank you very much, very sincerely, and look forward to continuing to work with you.
Thanks to you all, and good luck.
All right, bye.
Bye.
There's some opportunities now for those that are still with us to, if you wish to engage with SMART on an ongoing basis, if you have not already joined us, please feel free to come to these links. But we will be sending out an email to all of the participants that joined us, even for those that did not, and communicate through an evaluation form, a survey instrument for you to give us feedback, but also to share some other opportunities to connect with you going forward. So thank you all for the time and the energy that you've given. There's another session later on, and we will be happy to carry on. So please email us or contact us if you have not already. Questions and answers will be addressed as well as we can after the fact, and we will send those out to the group. So thanks everyone for joining for us today, and you guys everyone have a good time and be safe. Thank you.